so I think we will do like this. Since I will be moderating, once he goes on presenting the capsule slides over slides, I'll suggest maybe I will ask someone to ask some questions, and then I will complete that question. So, Dr. Darshan, please start.
Okay. Good morning, sir.
Morning.
I am presenting a case of 45-year-old male resident of Jaipur, Rajasthan, presented with the chief complaints of difficulty in swallowing food for the past 6 months.
Any question, Nijar, from your side?
No, sir.
Okay, see, if I am to ask you, why you stress that he is from Rajasthan? So what was your provisional thinking? Difficulty in swallowing food for past 6 months?
Sir, as a patient had the single chief complaint of difficulty in swallowing food, and he is a young male, middle-aged male, 45. So it is not the usual presentation for the malignancy.
So
I would like my clinical diagnosis towards the benign dysphagia more than malignant at this point of time.
Benign dysphagia for the last 6 months causes?
The esophageal motility disorder, or patient had the complaint of, as there is no complaint of GERD related, but if so, then there might be due to reflux esophagitis and long-standing GERD, there might be a peptic stricture in which can cause the difficulty in swallowing.
Okay, so motility disorders, strictures, peptic related, or malignancy possible?
Yes, sir. I would keep it.
Malignancy is possible, and benign tumors are also possible.
Yes, sir.
And non-esophageal conditions could be possible.
Yes, as the patient had no history of any corrosive ingestion, sir.
No, possibility. We'll go step by step. They are possible, isn't it?
Yes, sir.
Even if there are problems with thyroid, cardiac, tubercular, outside, pulling the esophagus and changing the contour, all these are possible in this patient. Suppose it is, if I stress the patient is from Rajasthan, what possibility epidemiologically you would bring into the diagnosis? What are the common cancers in Rajasthan?
In the North India, sir, there is a common
Rajasthan. I'm speaking of Rajasthan. So you should know what is the state-wise distribution of malignancy and what is the highest rate of malignancy in which state. So at present, as of literature, Kerala has the highest rate of malignancy. And Rajasthan even doesn't come under first 10 of states. And the commonest malignancy which is reported, that is from Jaipur only. The trend. They are the oropharyngeal, the tongue, the pharynx, the esophagus, and the lungs. These are the 4. Okay.
Okay.
So that's why if you are saying anything for first slide, I checked you because as we proceed, we are moving towards diagnosis. So your presentation should point towards the diagnosis.
Yes.
So we are at a very broad base of the pyramid, and then we will reach the top as we go out. Yes. Okay. Next slide.
He was apparently well 6 months back. Then he developed difficulty in swallowing, which was insidious in onset, with sensation of food stuck in the lower chest, and it is more to solid than liquid. And there is also associated history of weight loss and appetite. The loss of weight is 73 kg to 66 kg in over the 3 months. There is no history of any heartburn or regurgitation, associated chest pain, no history of corrosive ingestion, no history of hematemesis or melena, cough with expectoration or fever, no history of choking or coughing after swallowing, no history of hoarseness of voice, and also there is no history of backache or headache or any abdominal distension or palpable lump.
So, doctor.
Yes, sir. I would like to ask
please go on asking.
So, what is the progression of dysphagia? I did not mention here. What is the progression of dysphagia? Like, it is started like that. It's food stucking is same, or it's started with liquid and then progressed to.
So patient
started with solid, then
started with
progressed to.
solids, then it
You
gradually
did not mention
progressed,
here.
and
And
then it gradually.
this weight loss is significant or insignificant? 73 kg, 66 kg over 3 months. So you can mention here there
Sir,
was significant loss of
yes, sir.
weight loss. You can mention in
More than,
percentage also.
yes, sir.
This much percentage weight loss was there
Yes, sir. It is more than
last 3
5%
months.
in last 3 months. Yes,
You can mention here. So
yes.
that, and you can mention if it is significant or insignificant. Sometimes there is a willful weight loss is there of patient. So those things are there. So
Yes.
this is my submission, sir.
Dr. Rajendra.
Yeah. What are all the causes for weight loss in carcinoma esophagus?
So, as the patient having this difficulty in swallowing and the stricture is there, sir. So the he cannot take food properly, and there is
Okay.
also the regurgitation might be there. So the he cannot take the proper food intake its own.
That is one thing. What are the reasons?
The malignancy
What
related
is the mechanism of weight loss in malignancy? Why do they lose weight?
due to cancer cachexia. Overall,
Yeah, what is the reason for that?
I don't know, sir.
Yeah, basically it is tumor necrosis factor alpha which is secreted, which
Yes.
causes loss of appetite and loss of weight. There is reduced intake, reduced capacity to eat, and reduced desire to eat. Plus, there is dysphagia. And if there is multiple metastasis in the liver or other regions of the body, then there is consumption of glucose and there is a catabolic state induced by the various neurohormonal factors released by cancer, which results in weight loss and also muscle mass loss. Yeah.
And
So, what are the
yes,
other
yes.
causes of dysphagia that you can think of? In motility disorders, what is the difference between motility disorders and carcinoma esophagus?
So first of the duration of the dysphagia, sir. In the
Yeah.
motility disorder, there might be long history of the dysphagia, intermittent long history of dysphagia. In whether in malignancy, there is a short duration, insidious onset, and progressive dysphagia is there. Whereas in benign dysphagia, there is intermittent dysphagia which might progress to the
Is
which might progress.
achalasia intermittent or continuous?
Sir, intermittent dysphagia.
No. Achalasia can be progressive, and the difference is dysphagia is more to liquids than to solids
Yes,
because
yes, sir,
solids open up the esophagus by the pressure of gravity.
yes,
And also, there is a motility of the esophagus. If that is significantly advanced, you may get dysphagia for solids as well.
yes, sir.
And it's a progressive dysphagia. What is Chagas disease?
So it is a parasitic disease caused by Trypanosoma cruzi. Not
Yeah. What happens with that? What does
so
it do?
The A ganglion.
Yeah, it destroys the ganglionic layer,
Destroys the ganglia of the esophagus,
esophagus, and results in megaesophagus. Okay. Sir,
So,
please go on.
You said history, loss of appetite, loss of weight, understood. Heartburn regurgitation, you meant possibly you hinted at whether he had a gastroesophageal reflux disease
Yes.
earlier on as a precursor of the malignancy.
Yes.
Now he said history of associated chest pain. When you had asked about heartburn, which is a pain, what other pain you asked?
So I was specifically pointing towards the benign, due to pain due to the motility disorders. There might be the gripping type of pain during the swallowing of the food. So I was pointing towards that
okay.
one.
No, that's fine. That's exactly I was asking. And why did you ask about corrosive ingestion after this history which you gave?
For rule out the etiology.
Do you think with this history that he had a corrosive injury?
No, sir. But for the sake of ruling out etiology, I have just put
You
it.
can rule out many things. The answer is sometimes because it is a more or less not a good thing. They used to hide this thing. You have to extract from them.
Yes, sir.
You don't say it. That's why it is important. Hematemesis malina, understood. Cough with expectoration, fever. What did you mean to extract?
Sir, due to the any micro aspiration or regurgitation, the patient is whether it is he's having the pneumonitic changes or
And why choking, coughing after swallowing? What does
sir,
that mean?
if the disease progresses to the advanced stage, there is a possibility of the esophageal fistula. So whenever the patient take any food, there might be sudden onset of choking or coughing just after the swallowing.
What is globus hystericus? Can that cause this thing? So other than complications, that's at the upper end, the pharyngeal end, they can all cause this type of thing. The laryngeal involvements. And you said, and you asked for no hoarseness of the voice. Why?
Sir, due to the location of the disease and any enlarged node which is compressing the recurrent laryngeal, which
So
can
you
change.
wanted recurrent laryngeal nerve involvement, whether it is involved or not. Other than lymph node in recurrent laryngeal nerve involvement, which is usually by local extension or by nodal involvement, what could be other cause? One other cause, if you say, wherein there will be dysphagia and hoarseness of the voice, but no recurrent laryngeal nerve involved.
Sir, and any enlarged goiter, which can
One, and pharyngeal involvement and post-corrosives. Okay. Next slide, please. You asked for backache and headache.
Yes, sir.
Backache is understood. I think you asked because of bony involvement, isn't it? And
Yes,
why headache?
Sir, rule out any brain metastasis, sir?
What is the commonest presentation of brain metastasis in GI tract malignancy? Is it headache? One centimeter metastasis to the brain. Will it cause headache?
So it will cause seizure.
Yes. Seizures, and depends upon which place it is set. So my point of asking these things is you should know what you are presenting, not just that's the difference between MBBS, MS, and MCH presentation. Okay.
Yes, sir.
So no history of abdominal distension or palpable mass. What did you mean? What did you ask for?
Sir, in the to rule out the any peritoneal and the liver mets, sir.
So for malignancy.
For malignancy, sir.
Any benign? Okay. Next slide.
I want to ask one question. It mentioned that food is sticking in chest. Can you locate the dysphagia location by this history? Like this, you have.
That was actually though. Since we are already into 10 minutes, so I purposefully avoided that.
Okay, sir.
But definitely you should know that question whether the pointing to the dysphagia is related to the location or not. For example, if the dysphagia is at the lower end, where should be the pinpointing of the pain?
So then the growth might be at the level of the dysphagia or below the level of the below the level of the sensation of stuck in the food, because it is in the lower chest.
If it is in middle,
probable location, then in the middle thoracic or the lower thoracic esophagus, not the above the level of
no, not in that manner.
Localization is most accurate in which tumors?
Cervical.
And why? Yeah, why? Because there is striated muscle, there is skeletal muscle innervation, so localization is better. While you go lower down, it is smooth muscle, and it is autonomic system, so it's more diffuse. Usually, they all get referred to the xiphisternum or to the cricopharyngeal region. So, lower third will refer to the xiphisternum, and upper third, middle third will refer to the retrosternal region.
Yes. So that's exactly the thing you have to answer this concisely. Okay, next one. Next one.
So-
Yes.
Yes. He visited the physician and advised for the medical management for the same, but no symptomatic relief over the period of the 2 months. Then he visited the gastroenterologist and underwent the endoscopy and the biopsy. He also underwent CT scan after that. According to the report of the biopsy and the CT scan, he was referred to the oncologist and advised for the chemotherapy. He underwent 4 cycles of chemotherapy and the last cycle was received on 13th July 2020. After completion of the treatment, dysphagia improved and the appetite increased. Patient again underwent the endoscopy and the repeat CT scan.
Nirjal,
No, sir.
you want to ask any question? Dr. Rajendra? We will go in that order. Nirjal
Yeah.
being the junior most, you should ask first, and Dr. Rajendra,
Yeah.
and then I will. Okay.
Couple of questions.
Yes.
Going by this finding, why do you think they chose chemotherapy first?
So the disease might be locally advanced at the time of
Okay. What do you
because the
mean by
patient.
locally advanced?
So any more than or equal to T2 and node positive
Okay.
disease, sir.
Okay. So would it be a definitive chemotherapy or would it be palliative chemotherapy they would have chosen? What is the role of definitive chemoradiotherapy and chemotherapy? And in which tumors it's more effective?
So definitive chemoradiotherapy is given in the cervical esophagus squamous cell carcinoma, in which the morbidity of the procedure is high. So we choose the definitive chemoradiation in that patient.
Even for middle third esophagus, you can use definitive chemotherapy if the patient is not fit for surgery. If lung function is not good, you can choose for definitive chemoradiotherapy. Is it chemoradiotherapy or chemotherapy that is in vogue for adenocarcinoma?
Sir, in the recent studies, sir, recent trials, they choose the perioperative chemotherapy in the adenocarcinoma rather than perioperative chemoradiation.
Chemoradiotherapy, yeah. Okay, go on, sir.
So, what would be the diagnosis, Darshan?
So from this history, sir, I will have the malignant dysphagia in my mind, sir, because the patient is having
No,
sudden
that is all
onset
right.
of
Malignant dysphagia. What malignancy?
sir, CA esophagus and CAG junction, sir.
What CA?
So carcinoma esophagus and carcinoma gastroesophageal
No,
junction.
what carcinoma?
Sir,
Squamous adeno.
so adenocarcinoma, sir.
Why not squamous?
In the treatment history, there is no. They have given only neoadjuvant chemotherapy, sir.
So neoadjuvant
And
chemotherapy not given in squamous?
No, sir. The location of the in the lower thoracic esophagus, the usual histology is
So,
adenocarcinoma.
in other words, what were the pre-existing factors in your patient so as to say that you are having a esophageal malignancy?
There is no prolonged history of
Now,
gastroesophageal reflux.
is there any
No,
factor?
sir.
So you didn't find any pre-existing
I did-
factors.
Yes.
So if that is not there, why this cancer happened in this patient? Okay.
What are all
Now,
the precursor? Sorry, sir.
we
What are all the
we
precursor
will.
reasons?
Sir,
What are all the
please.
precursors of carcinoma of esophagus?
Sir, smoking, then prolonged history of gastroesophageal reflux disease.
Yes.
What is stylosis?
There are not only two,
Yes.
no? There are many.
What is stylosis?
So stylosis is a skin condition which gives you an indication that this possibly is a there is a pre-malignant status. These people are more prone to esophageal cancer, mostly squamous cell carcinoma.
And in
Okay.
What
females,
is
sir,
Plummer-Vinson syndrome?
yes, sir. In there is post-cricoid wave along with iron deficiency anemia in the middle-aged females.
No. Is it associated with malignancy?
Yes, sir.
That's what he's asking.
Yes, sir. It is associated with
So
malignancy.
you have to answer all them, not one by one. So give all the lists of pre-malignant conditions,
And
whether they are there with this patient
What
or
about
not.
chronic candidial infection? What about chronic herpetic HPV infection.
It
What is
can,
the importance of HPV in carcinoma esophagus?
so it can cause adenocarcinoma.
It causes squamous cell carcinoma. Just like carcinoma of the cervix, it causes squamous cell carcinoma. More likely is oral cavity and upper esophagus. Less likely is lower esophagus. Lower esophagus, most commonly adenocarcinoma, but you can get squamous cell carcinoma even there. And in that squamous cell carcinoma, they have isolated HPV DNA. So HPV is now the current cause of and the precursor lesion of carcinoma of esophagus.
Okay, so you should know the pre-malignant conditions and what is the percentage of association of which type of malignancy of the esophagus related to the pre-malignant conditions. That you should know. Now you said this patient had chemotherapy, so you are sure he was having adenocarcinoma or squamous cell carcinoma, nothing else?
So he underwent
In
upper
which
GI
other condition of esophagus you can give chemotherapy other than adeno and squamous? Lymphoma होता है?
lymphoma. Yes, sir.
कितना परसेंट में होता है? Very less. In a series of thousands of patients, they could find only 3 or 4. But the presentation is mostly bleeding, the commonest presentation. So the treatment is chemotherapy and at times radiotherapy. Neuroendocrine tumor of the esophagus, malignant neuroendocrine tumor of the esophagus. Do you give chemotherapy in these patients?
According to the stage of the disease and the differentiation, sir.
Malignant neuroendocrine tumor of the esophagus.
Yes, sir.
कैसे present करता है? How does it present?
So bleed probably, the hematomesis, upper GI bleed.
No, not hematomesis. The dysphagia, then neuroendocrine secondary hormone secreting symptoms like diarrhea, abdominal distension, hyperacidity. These are the common things, not bleeding. And there you give chemotherapy based mostly on cisplatin regimen. Okay. So if I ask, because you first presented the treatment history, so you should be very careful and be ready to answer all these questions. From the cycles of the chemotherapy, can you say what type of chemotherapy was given? We're not going into that because we'll go later on. Next one.
So there is no history of any similar complaints in the past, no history of any previous surgery, and there is no comorbidities. Patient is having vegetarian diet, non-alcoholic, non-smoker, no normal bowel and bladder habits, and normal sleep pattern. There is no significant family history.
Now back. Stop at this slide.
Yes.
Major, any question, Dr. Rajendra?
Did you ask for any history of skin changes, thickening of the palms and soles?
So he is indicating towards stylosis. Yes.
Sclerodactyly. Scleroderma.
So my question here is
acanthosis nigricans, necrolytic migratory erythema, erythema gyrata repens. You have to take these markers of skin disease.
Now, my point is you have presented the treatment history first. Okay. Now you are going towards past history. How does it help? So it's always better. My point, you won't be able to answer, I'm sure, because see, in this case, it's the patient will be saying his history. You have to frame your history according to your presentation. So I've been happy if you would have given past history, personal, family, and then the treatment history. The discussion would have been different. Okay. So now after the treating history, we have the diagnosis at hand. What past history is important now for this patient? Now, regarding the personal history, why did you ask for vegetarian diet? And you actually should ask for it. What are the protecting factors for carcinoma of the esophagus, which is shown to be the incidence in those cases? You think that should be high, but they are actually low. 2 factors. So one is a fiber. The mechanism is exactly not very clear, but they say that absorb the toxins or the acids. That is one. Second is H. pylori infection. H. pylori infection in CA stomach proper, it could be precipitating, but in CA esophagus, it is shown to be protective in epidemiological study. Cause not very clear, postulations are there. Okay, non-alcoholic smoker, understood. Why normal bowel and bladder habit you asked for this patient? Normal sleep
Normal.
pattern.
So, if
No,
the
just
patient
to
is having,
complete,
yes, sir.
but I said there are many things you can ask. So at this stage, better focus on your diagnostic aspects so that we can discuss more about your treatment and investigation part. That's where the decision making lies. Which family history is important for this patient? You said not significant.
any any history of malignancy in the
So what is the
person?
relation of family history of malignancy with CA esophagus? Means what is the genetical transmission rate in these patients? कितने परसेंट फैमिली हिस्ट्री में आपको मिल जाएगा? And what are
I
those
don't.
cancers? So esophagus
I don't.
malignancy is known to run in family, but in very lesser percentage cases, maybe about 5 to 10% of cases. Not necessarily it has to be carcinoma of the esophagus, but it could be other carcinomas also. So there is a genetic transmission, very less. So if a presenting must know how to answer it. That's what I'm pointing out. Next slide.
Shall I summarize?
So yes, please summarize.
A 45-year-old male without any comorbidity, non-alcoholic, non-smoker, had history of difficulty in swallowing food, more to solid than liquid for the past 6 months, is associated with loss of weight and appetite. He underwent endoscopy and a radiological investigation followed by chemotherapy. He had symptomatic improvement after completion of the chemotherapy. So my probable diagnosis is malignant dysphagia due to carcinoma of gastroesophageal junction or carcinoma of esophagus.
Sir Rajendra sir, please.
Why did you put G junction as the first cause? There's no history of reflux. There's no history of Barrett's. There's no history of endoscopic therapy for Barrett's. There's no symptoms of GRD in the past.
The patient,
So why did you think of carcinoma G junction?
sir, he is having complaint of food stuck in the lower chest, sir. And
I told you about localization. Localization is very inaccurate for lower esophageal malignancies. So please don't keep carcinoma G junction as your first possibility. It's an endoscopic diagnosis. It's not unless there is clear-cut history of GERD,
yes, sir.
history of Barrett's, history of treatment for Barrett's. You should not think of carcinoma G junction. You should be thinking of carcinoma esophagus and carcinoma stomach involving esophagus. So those are the two conditions you should be thinking of.
Yes, Nijar.
So, on the basis of chemotherapy, can you give your this diagnosis? Carcinoma G junction, like you have mentioned your history.
Yes, sir. In
the 4 cycle of chemotherapy has been given.
Because in the lower thoracic adenocarcinoma and the G junction, we give the same.
Like normally carcinoma esophagus, what therapy we give 45-year-old male patient. Weight is also adequate, although this is there. So normally, what regime we give in carcinoma esophagus?
Sir, in
the radiation.
Sir, in adenocarcinoma, sir, we prefer the FLOT regimen, sir. Whereas in the squamous cell carcinoma, the cross regimen is preferred. The chemoradiotherapy regimen cross in the squamous cell.
Okay. One more thing, in summary, you have
What is
written
the role of chemotherapy for carcinoma esophagus? Is there no role for chemotherapy in carcinoma esophagus? Squamous cell carcinoma of the esophagus. There are trials where it has been shown to be efficacious, but not as much as chemoradiotherapy. And it is definitive chemoradiotherapy. You don't give palliative chemoradiotherapy, you give palliative chemotherapy. So it could be palliative intent.
And even
what are the reasons for palliative intent? What intention is there? What do you want to achieve in carcinoma esophagus?
Sir, to address this systemic micrometastasis, sir, or
the intention of palliative chemotherapy is to ensure a good swallow. The aim of all treatment in carcinoma of the esophagus is to ensure a normal swallow. They should have normal swallow returned to them. So, yes, in therapeutic efficacy, Yes, if you have done a radical 3-field lymphadenectomy, that has improved survival. Oringer has shown that if you do a modified transhiatal esophageectomy, where you do a radical transhiatal esophageectomy in lower third carcinoma esophagus, there also survival is improved. But actually, if you see, there is no difference in the survival of chemoradiotherapy and surgery. So if definitely chemoradiotherapy is given, the results are similar to surgery in terms of survival. But normal swallow is better in surgery than in chemoradiotherapy.
So basically, your diagnosis of carcinoma G junction, I have to point out that G junction is at a junction of the esophagus and the stomach. So the symptoms could be presenting like esophagus, like stomach. So it's not that from your symptoms you can straightway point out that this is a case of G junction because of these findings or something. So better to avoid that one in your diagnosis. It's safer to say whether it could be a esophagus or a proximal stomach, rather than pointing out that it is a case of G junction. So commonly they present as distension of the abdomen, acidity, reflux, a mixture of symptoms. Okay. And regarding this squamous cell carcinoma, adenocarcinoma part, I would suggest not to completely be blind in saying that if it is a squamous cell carcinoma, I'll give chemoradio. If it's adeno, I'll give chemo. It's not like that, because if you are saying about some of the trials, maybe cross trial or so, they have included all the patients. So it's not that exactly this is the thing. And you also not be there. So many trials in C esophagus, G junction, and stomach, and so confusing. And finally, you have to tailor your patients according to their need and case per case basis. So some basic things at this level you have to be very clear. Either they are to be given or they are not to be given, or you have to keep your idea open that I can keep both the things. So we'll move on to that. Next one.
So patient is conscious, cooperative, and well-oriented, average build and moderately nourished, well-hydrated. BMI is 22.7 kg per meter square. ECOG score 1. Vitally stable. No paler icterus, cyanosis, clubbing, pedal edema, or lymphadenopathy, including the cervical nodes. The oral cavity examination is normal. No halitosis, no dental caries, no ulcer.
What does this general physical examination mean to you?
To assess the nutrition status of the patient, then overall.
How did you know that he is moderately nourished?
There is no signs of malnutrition was there, sir. Like
I'm not going into this physical examination in detail. If I ask you, why did you ask for cyanosis, clubbing?
if the patient was in smoker, sir, there might be the peripheral cyanosis and clubbing of the.
Your patient is a smoker?
No, sir.
Oh, so why did you ask? So, see, again, I'm just pointing out that be very careful in including the terminologies at MCH level. Okay. So we will exclude, we will just fast forward this slide, coming to the next one.
Yes. Sir,
Yes.
Systemic examination.
Nature yours.
Yes, sir. Please continue.
Yes, sir. On inspection, abdomen is flat, umbilicus is central and inverted, no fullness or visible lump, no visible scars of peristalsis, pulsation, sinuses, or engorged vein. No, near sides, no visible cuff impulse. External genitalia normal. The renal angles are normal. On palpation, there is a normal temperature. Abdomen is soft, non-tender. Liver and spleen not palpable. No other palpable lumps. And hernial sides, no palpable cuff impulse.
Nature.
Yes, sir. No question from my side.
Dr. Rajendra.
Yeah, only in the
Please.
general examination, you did mention oral cavity examination, you have to mention leukoplakia is present or not. It's a very important finding to say. And orodigestive malignancies are more common in carcinoma of esophagus, especially in smokers. Your patient is a non-smoker. Non-smoker. So you should consider HPV. So you should look for leukoplakia in the oral cavity. Also, you should think of conditions like Kaposi sarcoma of the esophagus in a young person. 45 is relatively young for carcinoma esophagus.
Yes, sir.
So you should think of Kaposi sarcoma secondary to age. So sexual history is also important. And you have to look for clinical findings suggestive of oral leukoplakia, which could suggest oral sex, which could cause infection with HPV. So these things you should keep a mind open and ideas open, especially when a younger individual is involved. Syphilis is another cause of orodigestive malignancy of the upper GI tract.
Yes.
So you should look for evidence of syphilis. So history of contact, all that is important.
So from the abdominal examination, you want to ask anything? Change to abdominal examination, your slide, please. So abdomen is flat, okay? And umbilicus is central. What does that mean? Umbilicus is central.
Patient is having any ascites.
So if
or
ascites is
abdominal
there, will
distance.
the abdomen be flat?
No, sir. Then the abdomen will be distended. The frank fullness will
So
be
your
there.
abdomen is flat. That's what I'm asking. Why all these things you have written? You have to think of this before writing. There's no fullness, no visible lump.
Yes,
Then
sir.
why the umbilicus should be distorted? Visible, no visible scar, peristalsis, pulsation, sinus. Why should there be sinuses and engorged veins? Sinuses, you should not look for, he will obviously complain that I have a sinus. Can engorged veins be there? In
Yes,
this
sir.
condition?
If the mass is locally advanced in it, or any metastatic nodes which is compressing the IVC or the superior vena cava,
Yes,
then
theoretically possible. Can he have cirrhosis?
he is non-alcoholic, sir. But yes, in cirrhotic, then maybe the engorge.
Can the
What is
the
chemotherapy cause
importance-
cirrhosis?
Sir, can I interrupt?
Yes, please. Yes, please.
Yeah. What is the importance of cirrhosis in carcinoma esophagus surgery? How does it alter your surgical plan?
Sir, we might find the periesophageal or perigastric collaterals in that patient, and it will make the surgery difficult in that patient.
Yeah, what about toleration of surgery? What is the relationship between child status and toleration to surgery?
Yes, sir. If the patient is child C, then he will decompensate in the post-operative period.
Yeah, B and C
Huh.
is,
B and C.
you have to be very careful
Yes, sir.
while subjecting them to non-liver surgery. You can precipitate liver cell failure. So that is the importance. So you need to know what is the implication of each of these statements, not just blindly write them down. If there are engorged veins, you are saying infiltration of the vena cava. Vena cava is way to the right. Esophagus is more to the left in the upper abdomen. So even a G-junction tumor to involve the IVC is very rare. More likely is portal hypertension, secondary to cirrhosis of viral or non-viral etiology. Nowadays, NAFLD is the commonest cause for cirrhosis. So you will encounter patients with cirrhosis of the liver without any predisposing cause. Yes,
So
sir.
what
Thank
does
you.
this abdominal examination reveal now? What it has added to our knowledge?
Sir, it mostly at the negative findings, sir. There is no any positive findings in the inspection or palpation.
What important negative finding?
There is no palpable liver or hepatomegaly is there. It will rule out the.
Why it should be hepatomegaly in this patient?
Sir, according to the location of the tumor, there might be increased chances of the liver metastasis.
So liver metastasis will cause enlargement of the liver. 2 or 3 metastases here and there, they will cause enlargement of spleen. So yes, I agree. The lump is not there. That means possibly it's not a very advanced one, or it is not from the stomach, the proximal part of the stomach. That is important, and there is no evidence of possibly dissemination in form of ascites and other things, and possibly no portal hypertension. Next slide, please.
So on percussion, liver span is 12 centimeter in the mid-clavicular line. Flank is tympanic. On auscultation, normal vowel sound heard. On digital rectal examination, perianal skin normal, sphincter tone normal, no palpable mass, and gloved finger stained with the normal stool without melanoma.
Why the sphincter tones would be defective here?
Will not, sir, in this way.
And what is this gloved finger stained with normal stool without melena? Is there a normal stool with melena?
No, sir. But patient, if the patient is having any
why the bowel
bleed.
sound will be disturbing? So you are writing just for completion. You must know the association of these things and the logistic approach from these findings to your diagnosis. Sir, should I skip the slide? This one.
Sir, I want to ask one thing: that do you
please.
expect any mass in DRE?
Sir,
in
if there is any, sir, if there is a CA carcinoma of proximal stomach or G junction or the lower esophagus adeno, there might be drop metastasis in the tip.
Carry on. You can carry on next slide.
Okay, next slide, please.
So respiratory system is
so basically we don't find anything abnormal here, isn't it?
Yes. Yes.
Next one. Next one. So your summary, it hasn't changed after your examinations findings and all this. It remains the same. We would again say that the diagnosis you have to change rather than saying that G junction the first. Okay, what did you do?
So first of all,
next slide.
Yes, sir.
So you want to go for investigations first.
First, I would like to review all the medical records. The patient underwent that biopsy, upper GI endoscopy, and CT scan. I would like to review that first.
Now we know all those things.
Yes, sir.
So in these patients, you will do these investigations. For what?
So first of all, I would like to do the upper GI endoscopy and the biopsy to exactly
you showed next slide investigation.
Yes. Yes.
How this back. How platelet is important here?
We are planning for the biopsy of the patient, sir. So if there is a
so do you think platelet will be less in this patient? Suppose this platelet shows 90,000. What does it mean? Is it possible?
What are the GI conditions that cause a low platelet count? You just tell, sir, then you will be able to answer the question. In CA esophagus, what is the most likely cause for a low platelet? Sepsis. Chest sepsis is the most likely cause for a fall of platelets. It could be an early sign of chest sepsis.
Yes.
And also
you are given chemotherapy. You are given chemotherapy. So bone marrow suppression can be another cause.
Yes.
Okay, so general investigation examination, routine blood investigation you did that shows a albumin of 4.2, and you are saying patient is moderately nourished. Is it okay?
No, so patient is well nourished. Albumin level is
so there is a discrepancy between your clinical and this one. So this thing again you have to be careful. GGT 90. Is it normal? Okay, next slide.
Yes, I do.
So if you go, so let's proceed. Yes, this is the major yours. So tell us the findings. You will go for upper GI endoscopy. Agreed?
Yes. So the upper GI endoscopy done on the 14th of May.
First of all, I would like that what do you expect in endoscopy? What is your purpose? What information you want in upper GI endoscopy?
Sir, in upper GI endoscopy, I want like to see the location of the tumor from the distance from the upper incisors, then the length of the involved segment, then status of the proximal stomach, then if there is any skip lesions is there or not, and the circumferential involvement of the involved segment and the overlying mucosa, whether it is ulcerative growth, ulceroproliferative.
Okay, read this.
So they have done the two successive endoscopy. In both of them, the circumferential fibril mass seen with luminal narrowing at the 32 centimeter from the upper central incisor, and scope is not negotiated any further, and biopsy was taken. In the second endoscopy, the stricture is found at the 33 centimeter. And in that also, the scope cannot be negotiated further. And both of the biopsy report are suggestive of moderately differentiated adenocarcinoma.
Dr. Desai?
How did you make a diagnosis of G junction tumor with these findings?
So the scope is actually non-negotiable, so I cannot
So can you
exactly
make a diagnosis? You can only say carcinoma lower esophagus.
carcinoma. Yes, sir.
And how do you define G junction tumors? What is Sievert's classification?
According to the epicenter of the tumor, sir, we the type 1, type 2, and type 3 tumors are described. In type 1, the epicenter is more than 1 centimeter above the J junction up to the 5 centimeter. In type 2, 1 centimeter above and 2 centimeter below the G junction. And in type 3, 2 centimeter below up to 5 centimeter of the G junction.
Sir, please go on.
There will be usually 2-3 questions here asked, usually asked in the examination. One is whether you should be very clear about the answer, whether you should go for a barium study or not. Is there any role or no role at all? That is one question.
Sir,
So the
endoscopists-
answer, usually people are very confused about this. Usually they just stop at this question. The answer is very simple. You can, whenever you are expecting a deviation in the axis of the esophagus or difficulty in endoscopy, or you're expecting extra esophageal disease. Now, earlier on, it used to be regular. Now it is these specific cases you have to do a barium to map out the anatomy as a roadmap for the endoscopy. Otherwise, they can cause injuries. That much is there here. And in non-malignant cases, motility and all these, the hiatus hernias, strictures, there it can be helpful for you. And second thing is, second question usually asked is, suppose biopsy is taken, biopsy is negative. You take again 2 biopsies negative, and you strongly suspect malignancy. And you want to know that I want to see the G junction. What should I do? So the answer is you should dilate. You should dilate and take further biopsy, and you can have a better visualization of the G junction condition.
Yes.
And we know we have already an idea that depending upon the type of the G junction involvement, the management may vary.
Yes, sir.
Okay, so these are the usual questions from here. And then we have a diagnosis of moderately differentiated adenocarcinoma. The third question will be asked is, the scope is not negotiable.
Yes.
How do you maintain the nutrition of the patient? So the answer, you should know, one, you would assess nutritionally what is happening, what is the intake. Still, they can be adequate with liquid nutrition, or else you have to pass an nasovaginal tube or nasogastric tube, or you have to do a feeding genostomy earlier. Those are the answers for this non-negotiation of the endoscopy. Next slide.
So they have done the IHC markers. L1 is negative in that patient.
Is it recommended to do in all cases? What is PDL1? PDL1. What? Now, like in simplest way, in bacterial infections, you give antibiotic. There is something that comes up, makes your antibiotics resistant. It is similar thing in the cancer treatment. And these receptors, when they are positive, they could evade your natural chemotherapy. And you should know what is the level above which they need therapy, what therapy, PDL1. So I hope you shouldn't have given this slide. Better to avoid this slide, because if you're putting this slide, then you have to know all these things. 1.68 is the critical level. Okay, and then they will automatically go towards the management. Okay, I would avoid this one now. This is not routinely recommended. Yes, in guidelines, if you go, then you find there are many other things also along with PDL1 are done. What are they?
HER2 status of
HER2.
Yes.
What is HER2?
Herceptin receptor is
What is that? Septin is a name. What else? You should know that since your time approaching, you have to go towards the surgical part. MSI instability,
MSI.
they also dictate what is your management. This next, please. Next.
Das sir, it's 10 o'clock. Yeah, will you continue or will you want to stop?
This is, I think it is 10 or it is, Acha, in
10.
my it is 52 minutes. I think we had 8 minutes more.
Okay, sir. No issues.
So, Dr. Rajendra, is it okay with you?
Sure, sir.
So he has a CT scan. Please
Yes.
Tell us the findings. We're not going into this. We'll straightway move towards the management.
Okay, so the patient is there is a
Important findings. Just tell us the finding.
yes, sir. So the location of the tumor is in the lower esophagus, sir, lower thoracic esophagus. The circumferential thickening is there in the lower esophagus. The adjacent fat planes are preserved with
That
the
is not the thickening. The thickening is clearly seen in the next one. Next cut.
yes, sir. The started from this cut section, and the luminal partial luminal narrowing along with thickening is there, and the fat planes with the aorta is preserved. And
Yes. So this part is resectable. G junction. So was the G junction.
yes, sir.
Is it involved or not involved? Yes.
Yes. So we can see the thickening is involving the lesser curvature of the G as well as the G junction and the lesser curvature.
This is the G junction where you can see the esophageal gas, air, as well as continuity towards the stomach. So is it resectable?
Yeah. Sir, it is locally advanced, sir, because it is involving the it will be the minimum T3, sir, involving all the layers of the esophagus, sir, and also extending to the G junction, sir. So upfront resection.
So G junction involvement is not a locally advanced one. G junction involvement is involvement.
Yes.
So there
based on what you're saying, that it's an advanced lesion, is it this test or is there some other test that you need to do for advanced lesion?
So PET scan, sir.
That will only tell you dissemination, but locally advanced, what is the test you will do? Transesophageal ultrasound.
So we'll endoscopic ultrasound.
You do an endo ultrasound and you then make a diagnosis of whether it's involving the adjacent structures, and you will be able to make a diagnosis. Obviously, there are no nodes involved, at least what I can see in the CT.
Yes, sir. So there is some
the crura of the diaphragm you have not shown us.
Here it is involved in this. Can you see? The crus is involved. There, this first row, last one. If you see, this is the crus, which is in continuation with the spleen. So most probably it is involving the crus of the most probably. And here the next one also you can see the crus is very close. Yeah, there where you were seeing. So for that, yes, you have to answer the endoscopic ultrasound is the best modality. From here, it appears to me that it is possibly locally advanced in the form of the crus, which is there. And you said you have done a PET scan. Does it show any difference from what you are saying from the CT? Obviously, there will be a lot of questions regarding your investigations, like why CT, why not MRI, why PET CT, and why not EUS in these patients. Those are the questions that will come up here, and those entail further discussion. PET scan, do you have anything for us?
No, sir,
other than what we are seeing in the CT scan?
So in the neck, they have just reported the mediastinal lymph nodes.
Yeah.
Otherwise, the extent of the lesion and
yes, in this you can see. So where is the mediastinal lymph nodes?
This one. In this section, sir, they have reported this.
Yes. So there is one mediastinal one. This is
And
one
the
mediastinal one.
and the retroaortic lymph nodes, they have also.
I'm not very sure whether the liver in this is having a metastasis or not. Looks a little bit
Looks like
more.
activity, sir.
Looks like
In the liver, in
activity.
the left lobe of the liver,
Yes,
left lateral
yes,
segment,
yes. They are.
they are
So I'm
there.
finding it, and we have a G junction tumor, which almost I think reaches the aorta. If you see the tail of this white thing coming up to the aorta, very small contact, but it is there.
Small. Yeah.
So you would be asked about the relation between the level or extent of contact with the prognosis or management of these conditions. Okay.
Yes.
Next,
They
go ahead.
indeed well, sir.
Go ahead. We'll go towards
Yes,
the
sir.
management. Go ahead. We have seen this. So we have mediastinal lymph nodes on this.
Yes, sir.
Further, go ahead.
So this is the
Now,
post.
what is, sir, yours. What is the
So, are
management?
there
How do we
liver
manage this
metastasis?
case? So Dr. Desai is asking a question. Please respond.
Are there liver metastasis?
No, sir. There is no obvious liver
In the
metastasis.
PET CT appears to be multiple areas of enhancement.
In the report, they have not given.
Not given,
Yeah,
sir.
which are present.
So sometimes there's a physiological uptake. Probably the physiological uptake can be there, sir.
Okay.
The actually on the one on the left lobe looks more than physiological. So you
But
have to keep
they
it in
haven't.
mind. You won't be surprised. In 15% of cases, you may find a metastasis there when you go down. Okay, how do you manage? So one thing, let us remove from this, that depending upon various trials, we will be giving a chemotherapy or chemoradiotherapy to this patient. And then after 2 months, we reassess with PET scan, which he has done, and seems to be a stable disease now. What is the management now? Let's discuss a little bit about the surgical management.
Yes. So the location of the tumor is in the lower esophagus, and from the scan it looks like a severe type 2, sir. It is extending to the G junction and lower esophagus, sir. So I would like to do this transthoracic esophagectomy, sir. The McEwan's esophagectomy, sir. As the patient is also having the mediastinal lymph nodes in upper mediastinal lymph nodes, sir. To
What
address
is the importance of lesser curve involvement in planning your surgery? Will that change your surgical approach?
Yes, sir. If the margin, the tumor is involving the lesser curvature, extending more towards the lesser curvature, it will affect the negative margin, the distal negative resection margin, sir. And we cannot use the gastric conduit as a, we cannot use the stomach as a gastric.
You can still resect the stomach and then see if you can pull it up. But if you cannot pull it up, what is your solution?
Sir, then
would you do an Ivor Lewis?
Yes, sir. Ivor Lewis, we can do Ivor Lewis, but
which is preferable? McEwan's with colon, or you will do Ivor Lewis in this case?
So in this case, sir, the stomach is not irradiated, sir. So we can take it. We can do the Ivor Lewis esophagectomy with stomach as a conduit.
Why did you choose against McEwan? Why not McEwan and a radical esophagectomy?
It's
what is your intention, and why have you changed your intention here?
So if the stomach is the gastric conduit can reach the neck, then I will preferably do the McEwan's esophagectomy with gastric conduit, sir. If there
would you
is
do a radical esophagectomy, or would you do just a routine standard resection transhiatal esophagectomy?
No, sir. Radical esophagectomy, sir. With
so in radical esophagectomy for G junction tumors, what are all the nodal distributions you will remove?
Sir, in G junctions are periesophageal lymph nodes, perigastric and periesophageal, the level 1, 2, then level 3.
Without resecting the stomach, how will you remove the perigastric nodes? See, you should think before you answer. So in G-junction tumors, you have to remove all the periesophageal lymph nodes and the upper gastroesophageal lymph nodes that are present. That is 1 and 2, and 3 and 4, if they're enlarged, you have to remove them. You have to do a concomitant resection. Especially if it's along the lesser curve, you can resect
Yes,
the
sir.
lesser curve. That will enlarge the conduit, that will make the conduit longer. So the conduit you can try, and if it comes up to the neck, you take it up into the neck, you do a separate incision, you do a laparoscopic mediastinal lymph node dissection, and you do a Iver Lewis. And the reason for that is, though you are doing a radical dissection, your intention is to produce a good swallow and a good quality of life.
Yes.
That is your intention. Survival advantage is an added bonus. Yeah, so you have to be careful. You will remove a rim of the diaphragm along with the crust, and you will remove all the nodes between the renal vein and the aorta left side. All the nodes in that area also have to be removed.
So all these are individual questions to you. What sir has said in a nutshell, every line of that is important and can be debatable, and you must be able to stand the questions related to this. But these are the basics of what he said. You have to answer. If I am to add, how do you? Because see, the treatment of esophagus malignancy, more or less straightforward. You can say, do they like this? Treatment of the stomach, more or less straightforward. You can stand. It is the G junction wherein you are confused and the examiner can pull your legs many directions. So the best answer for you at this point of time, leaving aside the debates, the trials and all these things, every statement what sir said has undergone trial, including what he said regarding the removal of the paraortic nodes. Paraortic node dissection removal is a completely different study in this business. Now, how to take a decision? Now, we have to understand certain rationale of doing surgery in G-junction tumors. We have 3 levels of lymph nodes in the chest, mediastinum, upper, middle, and lower, basic. And we have abdominal lymph nodes. In about 10% of cases, the lesser curve lymph nodes are involved in G junction. And in about 5% of cases, the greater curve lymph nodes are involved, including the left gastric nodes. So if it is a type 1 G junction tumor, then the chance of having upper and middle mediastinal nodes is about 15%. If it is a type 2, you can still have a upper middle and middle involvement of the nodes as well as the abdominal nodes. In type 3, mostly it is periabdominal, the lower mediastinal, very rarely upper and mid. So accordingly, you tailor your resection. So if it is type 1, you say that I will go for a right thoracotomy. Again, you must know the trials comparing the right thoracotomy, the left thoracotomy, left thoracoabdominal versus the transhiatal. And possibly you will be surprised to know that actually none of the trials have really shown superiority of the thoracic one over the transhiatal so far as the G junction is concerned, except possibly in some trials in type 1 where they have shown the better results with lymph nodal removal and little bit of survival advantage, little bit, not significant, over transhiatal. So type 2, again, they divide into 2 parts. One is more than 3 centimeter involvement, size of the node extent less than 3 centimeter. So more than 3 centimeter, they say go like type 1. Remove the superior, middle and inferior. Chance of nodal involvement is more. Less than 3 centimeter, better go towards the transhiatal one and lower mediastinum and the stomach. So type 1, if you say that I'll go for a right anterolateral, right thoracotomy, 3 nodal, all mediastinal node resection, and resect the stomach, do a frozen section, lift up the stomach for gastric pull-up. It's okay. Type 2, more than 3 centimeter. If you say like this is literature I'm saying. If they say, no, I don't agree with this, it's fine, sir. It's okay. So if it is more than 3, I go for, again, similarly like thoracotomy. Right has been shown to better than left in this yield, particularly doing the thoracic dissections and dissections of the esophagus. And surprisingly, type 3, the transhiatal esophagectomy in terms of survival as well as nodal, the survival has been shown to be a little bit better than the transthoracic, particularly keeping in mind the morbidities which are significantly high in transthoracic dissections and the complications of intrathoracic anastomotic leak. So whatever the DOTS trial which you have that shows that transhiatic in type 3 or type 2 with less than 3 centimeter would be a choice in this people. So this is how you have to go, but you have to answer something. Okay. Now, they will be also asking you little bit about discussion of the studies, the trials. Like you said, one is cross trial. You must know what is a flood trial. And then obviously a question here would be asked, tell me what are the trials? What is the nature of these trials? They have mixed population. They have esophagus, they have stomach, they have G junction. Then obviously the last question would be, which trial has taken 100% G junction tumors? Have an idea? That is the POET trial from Germany. Of course, they haven't been able to show much of a difference in management in different type of G junction tumors. Go by chemotherapy, perioperative chemotherapy. If at all you are giving chemotherapy, if you go by FLOT trial, you have to give perioperative. You must know what are the 3 drugs they are using. And then next, it will be, obviously, it will be asked, adjuvant therapy or not. You have to know 1 or 2 trials, adjuvant therapy, which has really not shown any benefit, particularly adjuvant radiotherapy has not shown any benefit, any use in these patients. Then what is the long-term survival? You must know that 5-year survival in these patients overall, which was 5-10%, has now reached up to 30% in these patients. Which subset of patients have better survival? That also you must know. And you must know about the palliative treatment of these conditions. Tracheoesophageal fistula, how to manage, support dysphagia, extensive disease, how to manage the palliations. And finally, now the coming of treatments, they may ask you regarding the role of immunotherapy and biological therapy, which is coming up in a big way. Now, how to decide giving it. And finally, you have to know the algorithm. That in this patient, this much of patient, this group, this much percentage will have stage 1, this much percentage stage 2. If stage 1, I'll do this, T1, T2, I'll do this, T3 onwards, I'll go put them into this regimen and then decide after 2 years by 2 months by doing these investigations regarding the stability of the disease. If they have gone to metastasis, then what are the options I am having? So these are numerous questions associated with G junction or C esophagus. So we have reached the time with due permission from Dr. Rajendra and Nijar. I think if you want to give some few lines of advice to him, it's okay. Otherwise, we can.
No, sir, you have thoroughly covered everything.
Nijar, can we close?
Sir, we can
Yes,
close,
sir.
sir.
Yes, sir.
Darshan, thank you very much.
Thank
It was
you,
a
sir.
very
Thank you
nice
very much.
interaction. You answered very well. So I think you have taken some of the points which sir said, Nijar said, and I said for better presentation next time. These are process of evolution. Don't say that the first presentation I did so bad, so good or something. So just write it down and try to correct. And so also for all the participants who have used and were part of this, I thank you all. Thank you organizers. Thank you, Professor Kapoor. Thank you all.
Thank you, Das sir, for sparing the time for. And I request Das sir for surgical part of this patient will do in the next session. So I will inform you in previously. before regarding the surgical discussion. I will ask Darshan to prepare a surgical preparation for this such type of patients for esophageal
Yeah,
carcinoma.
this is necessary. We are MCA GI surgery, and we should actually have devote one complete session for esophagus. Normally, that's what exactly happens in the examination. First two cases, by the time you reach the surgical part, so the gas is over. Then we are for the next candidate and all this. So, but on third or fourth case, they will just tell you go for your summary and then jump over to the details of the surgical. And surgical will also be asked as a part of the operative surgery and viva. So this
Yes,
would
sir.
be discussed in very detail, including the procedures, the technical aspects, the instruments used, and different situations. All this should be discussed actually.
Thank you, Das sir. Thank you, Dr. Nirajan and Dr. Rajendra Desai sir, for moderating today's session. Thank you, everyone. We are closing
Thank you,
today's
Anand.
session.
Thank you, Dr. Anand.